I'm Dr. Neil Skolnick. Today we're going to talk about preoperative evaluation. This is an important topic. It's something we're often asked to do, and we're going to go over the new American Heart Association, American College of Cardiology guidelines for perioperative cardiovascular management for non-cardiac surgery. The most important thing is to use a stepwise approach to decide when surgery can proceed as planned, and it doesn't happen often, but it is really important when it does, when surgery needs to be delayed in order to do a further evaluation or provide treatment before a patient can proceed to surgery. The second large thing we need to know is how and when to hold certain commonly used medications before surgery. There are two main components of cardiac risk when we think about preoperative evaluation. First is the level of risk of the surgery. The second is the patient's cardiovascular risk. High-risk non-cardiac surgeries include suprainguinal vascular, thoracic, transplant, and neurosurgery. Intermediate risk surgeries include general surgery, otolaryngology, genital urinary, and orthopedic procedures. Low-risk surgeries include endocrine, breast, gynecologic, and obstetrical surgeries. Very low-risk procedures include cataract surgery and other ophthalmologic surgeries, dental procedures, endoscopic procedures, and skin biopsies. Though preoperative evaluation prior to low-risk surgery is something we're often asked to do, the guidelines state, and here I'll quote, "Little evidence exists to support extensive preoperative testing in patients planned for low-risk surgeries." And this is particularly true for very low-risk procedures. The first and perhaps most important step is to evaluate a person's functional capacity. This can be done with a careful history or by the use of a validated tool. This guideline states that in most cases, someone with good functional capacity can proceed with the planned non-cardiac surgery without further testing. That begs the question of what is good functional capacity, and here the guidelines are somewhat vague and there is room for clinical judgment. Another thing to think about is frailty. It is very clear that frailty, which is increasingly common with age, is a marker for adverse outcomes after surgery, and frailty identifies someone where the risk-benefit of elective surgery needs to be carefully weighed and discussed, and a decision made about who may need careful perioperative management. Now, for patients with known cardiac disease, and for asymptomatic patients undergoing elevated risk surgeries, a preoperative EKG is, and the guidelines say, reasonable, in order to both establish a preoperative baseline and to guide perioperative management. If the EKG shows new abnormalities, then further evaluation may be warranted. For asymptomatic patients undergoing low-risk surgeries, an EKG is not needed. In a patient who has new onset shortness of breath or physical exam findings of heart failure, evaluation of left ventricular function, an evaluation that includes getting an NT-proBNP and an echo, is recommended before surgery can proceed. Let's now talk about the recommendations about when to perform stress tests, and here there's room for clinical judgment. The guidelines give a 2B rating, meaning a weak recommendation, with the statement, and here I'm going to quote, "Patients undergoing elevated risk non-cardiac surgery with poor or unknown functional capacity and elevated risk for perioperative cardiovascular events based on a validated risk tool, stress testing may be considered," unquote. The guidelines then go on to say that in select patients in whom high-risk ischemia is suspected based on symptoms or other factors, stress testing may be useful. The guidelines then go on to acknowledge, though, that the positive predictive value of an abnormal test is modest, and it's not clear that an abnormal test provides incremental prognostic value beyond standard risk assessment. What do we do with this? My take here is that if someone is symptomatic, then they warrant further evaluation with a stress test and an echo. And if they're not symptomatic, then there's not clear value or clear need for stress testing. It's interesting when we think about it, this is not that different than our approach to stress testing in general, whether or not surgery is being planned. Let's now tackle a few specific things. First, hypertension, very common. In general, continue a patient's antihypertensive regimen, but be careful about uncontrolled hypertension, which is associated with a greater degree of perioperative complications. If someone's blood pressure is above 180 systolic or 110 diastolic, then consider delaying elective surgery until better blood pressure control is achieved. If someone has decompensated heart failure, and I think we'd all recognize this, elective surgery may be postponed. Patients with moderate or severe valvular disease, that is aortic stenosis, mitral stenosis, or mitral or aortic regurg, should be evaluated by a cardiologist with consideration for an echo and then further management depending upon the details of the evaluation. In patients with a recent stroke or TIA, it's recommended to delay elective surgery until 3 months or more after the original event. Finally, remember to hold or adjust specific medicines prior to surgery. These include the SGLT2 inhibitors, which should be held for 3 or 4 days prior to surgery. GLP-1 receptor agonists should be held for at least a week before elective non-cardiac surgery for weekly dosed GLP-1 receptor agonists and the day before for daily dosed GLP-1 agonists. The reason for this is the risk of delayed gastric emptying, potentially leading to an increased risk for aspiration. Then the decision about antiplatelet agents for people with coronary disease and anticoagulation for people with AFib or venous thrombotic disease, DVT or PE. There we have to balance the risk and the benefit, and it's dependent on the details of their disease and the surgery that's being planned. If you're uncertain here, then reach out to the patient's cardiologist for advice. When oral anticoagulation is interrupted, for most patients, bridging with heparin is not recommended. See the guideline for details about the length of time to stop DOACs or warfarin prior to surgery. The bottom line for us in primary care, we do a lot of preoperative evaluations. Often we are asked to do preoperative assessment that's for low-risk surgery, and the perioperative cardiac risk is low. For patients who have good functional capacity and who do not have symptoms of cardiac disease, the risk of surgery is acceptable without further cardiac testing. For patients who have cardiac symptoms, either chest pain, shortness of breath, signs of heart failure, or moderate or severe valvular heart disease, we should put on the brakes and do a further evaluation. If we're uncertain, then it's reasonable to ask for additional cardiac clearance from our cardiologist colleagues. Also remember, this guideline is focused on cardiac risk. Not all surgical risk is cardiac. Remember the lungs. Think about people with severe COPD. Also remember things that are miscellaneous, like if someone was on significant amounts of steroids over the last year, they may need stress dose steroids. I'm interested in your thoughts, how you approach preoperative evaluation. Please leave them in the comments section below. I'm Neil Skolnick, and this is Medscape.